Hi.
Hi,
So finally get to do this session with you.
that's right. It's been a while.
Yeah, it's been a while since we've
But
been
then,
planning on doing this, but somehow something or the other just kept happening, and the last one was just
yeah, no,
crazy. I
that was
mean,
yeah. I'm really sorry to hear that though. Yeah,
yeah, I mean, a very young man just lost his life, just like that. I mean, it was like, it shows the
tragedy
fragility of life,
of life. Very
Yeah,
true. Very true.
and it really shakes you up that what are you doing, But anyways, that's something which we'll all have to cope up with.
Hmm.
It'll take a lot of time. But like I said in my post, the show must go on, and we are back here.
Yes.
So Doc, welcome to our channel, and I'm so happy to have you over for this session.
Very happy to be here, and I really admire all the effort that you have been making in the past to create awareness, to talk about new things. I think endometriosis, the more we speak about, the more we talk about, it's only going to help, no matter what knowledge you get from where, because often enough people don't know what they're going through, and very little people who probably can guide them as to what's right and what's wrong. So
Absolutely.
anything that you do for making people aware is only going to help us in the endometriosis community to actually get the right support they require.
True, absolutely
Mm.
true. So, just a small intro about this amazing person with me, Dr. Anshumala Shukla-Kulkarni.
Yes.
She is one of the most well known and well experienced gynecologists and laparoscopic and robotic surgeons practicing at Kokilaben, Dhirubhai Ambani Hospital and Medical Research Institute, Mumbai. So she has done her advanced training in Singapore and Australia and previously has worked with prestigious hospitals like Saifi Hospital, Mumbai and St. George Hospital, Sydney. And today we are going to be talking about something that is really important, extrapelvic endometriosis and the role of technology when it comes to endometriosis. So, Dr. Anshumala, I am eager to start this conversation because there are so many questions, so many things that are there in the mind, and this session probably would be long. So, just a disclaimer.
Yeah,
So, so let's just jump in directly to the questions.
sure.
Can you describe any unique or unusual symptom that the individual experienced before receiving a diagnosis for endometriosis?
So when you start seeing a lot of endometriosis patients, we all know they're going to have pain and the obvious signs where somebody has infertility and then they come and get diagnosed, and it's very easy to jump at it. But then you have someone who comes in with the symptoms which are often enough. So, like, I've had these unusual patients who've been referred to me because of other specialities sending them to say, look, I don't know what's wrong. Maybe it is God, because I keep talking about endometriosis so much in my hospital as well. So now everybody in the
Correct.
hospital that I work in is sensitized to this disease. And it so happened that we had our oncology thoracic onco surgeon, and he had this nun who came in from the Middle East. She was working there. She belonged to Kerala, and she had come in with repeated pneumothorax. She would get this and
Oh,
difficulty in breathing, and then obviously nobody asked her anything about her periods, and she landed up with the thoracic surgeon, the thoracic oncology surgeon, saying that there is some mass that they're seeing on the CT scan, and they're not able to find out what it is. And she gets this continuing pain and hemothorax, pneumothorax happening all the time on the especially on the right side of the patient. So he
okay.
said, he saw the CT and he thought, okay, let me see what it is. He does thoracoscopy. He does the same thing as you do laparoscopy for the tummy. You put a telescope in the thoracic cavity.
Correct.
You don't have to make a big cut and you can look. He looks in and he sees these bleb-like structures and, of
Mm.
course, a brown, powder brown mark happening in the pleural space. And that's when he kind of clicked to him that, okay, maybe this is not just a mass, is probably is endometriosis. And he just goes ahead and calls me in from my outpatient and says, like, please come and have a look at this. We need you to see this because we just want you to confirm if this is something that actually it comes from what you deal with. And I go into the OT, and yes, this was very typical endometriotic lesions with blebs. So the inflammatory vesicles that you generally see, these are like blebs water-based blebs which you see all around. These are inflammatory markers you see on the covering, on the pleural thickening covering. In the peritoneum also you see it. And then behind them you had these marks of powder bone thing. So then he finished his part of the surgery. We got the patient out, and then is when I went and spoke to her after the surgery was done and everything, and she was in recovery, to check with her what were her symptoms. And of course, she said that this was there, but nobody had thought of correlating this with the period cycle. Nobody ever spoke to her about it, asked her whether this is actually related to anything like that. Then when I started asking her, she said, yes, she has extremely painful period. Painful period is something that she's always been, we always had it ever since she was in school, but she always thought it was fine, and she never thought until she started developing this is when she went to seek a doctor. Otherwise, she was just popping medications, going about her work in the church, and she never thought of actually having that painful period checked, and how they are not active, they're not active sexually also. So for them, these symptoms probably was not something she thought about, that the pain should be something very different that I should be dealing with or even asking help for. So we get the MRI done, we get the ultrasound done, we find out that she had large endometriomas, she had a full Poucher Douglas, which is obliterated, like a typical stage for endometriosis.
Correct.
Of course, we treated all of that as well for her, and she's well now, and she's come back, and of course now she doesn't have any of things. But this was someone who came into the thoracic oncology. And
Correct.
then, I get called in the middle of their surgery and it was only and only because I think maybe the diagnosis would have come through if after the histopathology had come, and I would have not had a chance to see. And it's only because of the sensitization that all the doctors in the hospital have, and I keep talking about endometriosis so much, that he thought of it. And he said, no, maybe, we should get her to come in and see this because this could be related to it. So this is some of the bizarre ways in which, endometriosis actually comes to you. And oddly enough, of course, nobody would ask. I mean, if you go to things like, I had a patient who had come in from Canada, and she used to have not much of dysmenorrhea, not much of painful periods, not much of a thing, but she had IBS-like symptoms. Now, we all know bowel symptoms are so typically associated with the endometriosis patients. Correct. Because of their inflammatory nature and their sensitivity to certain things in the diet. But nobody had actually pointed that out to her. That maybe she was told that maybe she has Crohn's, maybe she has, put her off gluten, put her on all of things. She lost massive amount of weight because she was put on all of these medications. And it was obviously going to take typically about 6 months to get an MRI done, because that's how the health system works in that place.
Right.
So she comes back, So she comes back to us, and she came to me because she thought she should get an opinion about her periods as well. And she was seeing a gastroenterologist as well. So we said, let's get the MRI done. And of course, she had endometriosis. And all it needed for us to do was, she was already 48. She needed a hysterectomy, bilateral sulfing oophorectomy, counseling with regards to diet and everything. And she goes back and she has no pain. She was actually referred to a psychiatrist by that time in Canada, saying that your pain has no meaning. It's not going anything. You've taken everything and you're still having pain. So, you need to go and see a psychiatrist. And she says, I can't be thankful enough for this. I mean, I just wish somebody had listened to me, or I had access to getting a better diagnosis done before, I had to go through all of these things. And then there was another patient who had come in. She's actually a medical student, and she used to faint in the wards. She used to just drop, she used to just faint because the pain, she would get sudden excruciating pain. But that pain would be lasting only for about 2 days after the period is kind of on the end. It was not like not a very painful period per se. And she had started developing a nodule in the inguinal region. And and then everybody started talking to her. Maybe you are working in a medical college. Maybe it's tuberculosis, maybe it's infection, and all of that. And it was a proper nodule. She had actually developed She had developed an endometriosis in the canal of Nook. So this is the canal which connects from inside the abdominal cavity to the outer area where the start of your mons pubis is. And any blood that is tracking along in that area can actually form like a mass, which was endometriosis essentially. But then her pain used to strike her just after the period, probably when the fluid had collected. There is when she used to get that extreme pain, and during her rounds in the hospital, she used to just suddenly faint. She was told all of this thing, but then she thought of coming into a gynecologist, and then that's when we said maybe this is endometriosis. Some patients have had FNACs done for this. So
Correct.
FNAC is like a fine needle aspiration. So this is a lady who comes to me who is 45, and she has a mass in her vagina, okay, and painful mass, painful periods, very hard mass, which the gynecologist has seen, looks at it and thinks maybe it's malignancy, does an FNAC from the vagina to diagnose this because they couldn't understand what is this Pauchi Douglas mass which is there. Uh, the diagnosis did not show anything conclusive, whether they didn't get a proper sample or whether it was just fibrotic tissue they got in it, God knows what. She comes to me, and of course she had a huge Pauchi Douglas nodule extending up to the vagina or into the rectum, and we had to go ahead and do a hysterectomy, BSO, do a rectal segmental resection for that, remove that inside that part of the vagina and suture it back again. So now this patient was being told you have cancer. This is a hard mass, and like you probably thought of it as being a cervical cancer or some bizarre thing that could have happened. Another patient again who was told she has cancer is an old lady. She's menopausal. So, generally how
Yeah.
we feel menopause is some time when obviously endometriosis lesions do respond to hormones, and they do have a synergistic response as endometrial tissue would have, similar to the endometrial tissue. But they can still grow even if you become menopausal. That is something not recognized or not talked about or not thought about also by a lot of people. Patient comes with mild spotting and
Hmm.
abdominal discharge. Okay. And they do a pap smear. The pap smear shows abnormal squamous cells of uncertain, what ascus it is called. Okay. So when they see this, they say we have to do hysteroscopy to find out where this is coming from. Cervix is flush to the vagina. You can't really see much. Ultrasound doesn't show anything. They try to put the hysteroscope inside, can't see anything. There are too many adhesions inside the cervix. They just can't associate and go inside beyond that particular thing. And she got very scared. She thought maybe, I've developed some advanced malignancy, not
Yeah.
even able to take a biopsy. Maybe there's something else. So we decided to do, she came to me, we decided to do a hysterectomy. And of course, the endometriosis is in the cervical canal. And this endometriosis was active, and it had caused adhesions in the cervical canal. So you could not put a telescope inside the cervix. You could not see anything, but she was having symptoms. So it postmenopausal lady with all of these things. So I mean, this thing can present in so many ways, and like I said, different specialities have actually brought these patients to me to say that maybe this has got something else to do with you and not really. That's for
So,
some of the bizarre cases that I have seen.
so what, like we have been saying this earlier also, day in and
Hmm.
day out, that they are, so first of all, you need to be vocal about endometriosis.
True.
People need to talk about it, because people otherwise, even the doctors per se, don't know what exactly it is, how to
Hmm.
diagnose it.
True.
So only when you start talking about it, people are, like you said, that people in your hospital are sensitized towards
That's right.
endometriosis. So at least they have a clue. Right. And
True.
secondly, obviously, taking an entire history, a 360-degree history is something
Very
which
true.
may really help.
Very true.
So what were, you just told me about the atypical locations.
Hmm.
So did the individual exhibit any other thing, like besides pneumothorax or bowel problem, IBS? Are
Hmm.
there anything else which are associated?
Hmm. So patients have had sciatic pain. They have been
Mhm.
to spine doctors, and they've had sciatic pain radiating all the way down to the leg. And this patient had gluteal pain actually, not so much of
Mhm.
sciatic pain. And again, here the symptom was not anything to do with periods and pain, but she just had this isolated pain in the sciatic nerve on the right side. And this endometriosis generally goes to the right in the sciatic nerve. And so what happened is that she had ultrasounds done. She'd not had MRIs done, and she came because some other doctor had done a hysterectomy for her, left the ovaries back,
Mhm.
and then she kept having this pain. And at that time, the reports showed mild adenomyosis and nothing more than that. She had her ovaries in place, but she had this pain, the sciatic pain, and typically going down the leg, inability to walk. So when she came to us, we did an MRI for her, and MRI is the only way to diagnose sciatic nerve endometriosis. And because she had these symptoms, we made it a point to make sure that we do an MRI which focuses on the pelvic nerves. and she had about a 1.5 centimeter lesion sitting on the sacral nerve roots. So we went ahead
Okay.
and did and excised it. Of course, he did a oophorectomy for her as well. She was 46 years of age, but she did well post that. So again, this is, you know, a symptom which uh, didn't have anything to do per se with endometriosis and typical symptoms, but just kind of you know, showed up as having an irregular, uh, I mean, an irrational pain, like a sciatic pain, which is coming up. So
That's right.
yeah.
That's right. So, what were the challenges that this particular, I mean, any particular person who has extra pelvic endometriosis generally faces when it comes to, you know, diagnosis of endometriosis?
You know, patients who have endometriosis have challenges even if they have pelvic endometriosis to get diagnosed. So it's really hard. I think most of the pelvic extra pelvic endometriosis, they have to be diagnosed. It would probably happen at the time of surgery if the surgeon is good enough to look at the appendix, look at the liver, look at the diaphragm, and make sure that they are looking in other areas as well. Otherwise, it's merely going to be a question of trial and error. They are going to find, because they are not going to come to the gynecologist first. They are
Correct.
always going to go to another specialist who's going to then try and see what they can rule out before they can actually come back and see. Like we had a patient who actually went to a urologist with stones. She had
Yes,
stones, and
somebody has
he
put that in the comments.
yeah, and she had her MRI, her CT-KUB, a beautiful
Hmm.
picture of one side small stone, with the other side a large hydronephrosis and hydroureter, and she had extrinsic endometriosis on the ureter. So this is
Hmm.
again, she for her to diagnose this, the urologist is the one who actually picked it up on the CT scan and then referred her on to me. So they will generally go with other symptoms. I think you know, their challenge is to make sure that the other specialty recognizes this as a problem which is related to endometriosis and then
Hmm.
refers them on to you know, the gynecologist. Also, I think radiologist and ultrasound, so if whether it's MRI or ultrasound, they also should be aware and think of this as one of the differential diagnoses for you know, patients who have endometriosis. So I think that challenge for a patient essentially would be that if they go to someone who is not, or of course if they don't get better and they have a problem, you know, that needs to be figured out. There was a patient who had come in. This is in when I started working in Kokilaben when in 2009, and this is one of the first 6 months patients who came in as they come from overseas for treatment, and she has come in with infertility and extreme pain. We did an ultrasound, and we found that she had endometriosis, she had endometrioma, she was very keen on pregnancy. But you know, an abdominal ultrasound at that point of time was not done for whatever reason. I did just did a pelvic ultrasound. We found this out. We put the telescope inside. We saw all of this, and the ureter seemed very dilated at that point. That's when we went back to look at the scan in the abdomen scan, and we found that she actually had a hydroureter hydronephrosis on that side, which was silent. She had no symptoms, absolutely no symptoms, and she we had to put a DJ stand. Of course, that kidney did recover, thankfully, because I think the time period for that was not as long. So her kidney did recover partially. She went on to have an IVF and have baby. She keeps sending me pictures of the baby even now. So it's like 2009 that we did this. But you know, this lady, if she had not had that abdomen, pelvis, and we had not looked at laparoscopy, seen the hydroureter, I mean, who knows? You know, if you were medically treating or not looking at the kidney, then you should have lost the function of the kidney. So it's all upon you know, the radiologist also to make sure. So if you know, even if you see a radiologist is doing a pelvic scan and you know they see endometriosis, I think it doesn't take very long to just go up and have a look at the kidney as well and see. You know,
True.
you know, so
True.
if that happens, I think it really will help a patient to you know, get diagnosed better. Otherwise, it can pretty much become difficult. Yeah.
True. I mean, obviously, role of a radiologist is something which cannot be neglected because the thing is, they are the ones who really can do a right diagnosis. Because I remember going for ultrasounds, God knows how many times, coming up
Oh,
with a clear ultrasound. and being
Okay,
told that
yeah,
there is just nothing. There
right.
is just nothing. And that's a story for another day, but any which ways. So
Yes.
what I was wanting to check is, are there any particular diagnostic tests besides radiology, obviously an MRI or an ultrasound? Are there any specific tests, diagnostic tests, which you prescribe in cases of especially extrapelvic endometriosis?
Uh, MRI of the chest and diaphragm is one that comes most commonly, and I think that is one of the most, that and then having an MRI done specifically to look for the pelvic nerve roots and the spine.
Mm,
So these are the two things that if the patient is showing significant symptoms, there is an algorithm of actually assessing a patient in the outpatient for endometriosis, and you it's more like it's used overseas as a printed algorithm. We can have it adopted to India. I'm not sure how many of us use this, but basically it actually charts the pain map for the patient.
correct.
So you
Mm,
have a chart and you are actually going to map where the pain points are, and any unusual symptoms are marked out there, which would give you an idea if you want to kind of go ahead and do a little extra investigation. Would you like to have an MRI of the spine or the pelvic nerve roots? Would you want to do an MRI of the chest? So these things can be done. Sometimes a colonoscopy is done, and by chance they see endometriosis, rectal endometriosis happening there. Of course, that's not something which we advise. Colonoscopy really is not required for more than 2% of patients of endometriosis.
mm.
But getting an MRI of the pelvic nerve root, spine, and chest, I think would be the additional things that I would want to get done if the
So when a
patient
person
has
is
those
going,
symptoms. Yeah.
yeah, sorry. So when a person like me, I mean, for
Yes.
example, when I had problems, okay, so
Right.
here, obviously they don't do pain mapping, right? So
Hmm.
now when I go to a doctor or when
Hmm.
I go to an MR, a radiologist,
Hmm.
so is it just the pelvic region which I should get a MRI done for, or is it because endometriosis, as I've been studying, is present almost
Anywhere.
everywhere,
Everywhere.
so,
No,
how do
no,
you?
no. So an ultrasound is almost always going to be abdomen and pelvis, always.
Mm,
Okay. And MRI, if we are on ultrasound seeing something related to the kidney or the ureter, then I
mhm,
will do an MRI which is extending to the abdomen as well. If the
mm,
patient has diaphragmatic symptoms, pain in the scapula, pain in the right side of the abdomen, then yes, I will ask them to do an MRI of the abdomen also, so that we have make sure that we have looked at all of these points.
all right.
Yeah.
So Doc, how do you think that a healthcare provider
Mm-hmm.
and specialists, all the specialists, how should they approach, when it comes to extrapelvic endometriosis, which is atypical in nature mostly?
So, a very good and wide range of suspicion. So, keeping your mind open about it and knowing that this unusual symptom may well be it. I mean, it's okay if you have a negative imaging and, or maybe even a laparoscopy, you look at it and you find there's nothing on the diaphragm. That's okay. But I think knowing that you should look and keeping an open mind about, quantifying those symptoms. So, like I said, this algorithm actually really helps, because if you have, when you're speaking to the patient, yeah, and you may be busy in the outpatient clinic, you may be having other things to do, someone calling, some reference, some this, that, all of that keeps happening, and the endometriosis patient is sitting in front of you. That requires the utmost amount of concentration and attention to list out their little list of things that they may be complaining of. But it will be a very small thing. Like I sometimes I pass the blood that comes out does not come out from the vagina, it comes out from the urine passage. And they'll just, by the way, casually say it and think it's okay, like it's not something. But that's something that you should just pick it up immediately. So
Correct.
that's where probably having an algorithm where you have all the parts of the body, like literally all the systems of the body listed,
Mm,
and then you start ticking there to say, okay, maybe I should look at her respiratory system. Maybe I should look at the diaphragm. Maybe I should look at the bladder more carefully in this patient because she's having these symptoms. And
correct.
the patient may come up with urinary symptoms of frequency of urination, inability to pass urine very well. And this is like a hypogastric nerve compression that's happening there. That's where the bladder is acting up. Patient is not going to say, sometimes, patient will say just this, that she has this, and then will, by the way, casually say she has painful periods also. You examine her
Correct.
and you find a big nodule in the pouch uterus, and that's when you know that it probably is hypogastric. And recently we had a patient who we did a hysterectomy. She used to find it difficult to pass urine. She used to take a long time. She's saying, even I didn't think it is wrong. I used to keep pressing my abdomen to pass urine. I didn't think it was wrong. I said yes. And then immediately after surgery, when she finds that she's now feeling much better and is able to pass urine well, she just said, my God, I can't believe that I used to have so much of an effort to just pass urine, because that's how my bladder was working. So as a practitioner, I think paying very, very close attention to the littlest of symptoms, and jotting them down, I will help you to mentally map where you feel that you could look for endometriosis for a patient. Yeah.
That makes absolute sense. And also what I feel is, by mapping it, like you're saying, I think patients also start thinking about it. Because a lot of times what happens is you start thinking that that's normal. You know, maybe that's how it is. That's how I'm made. You don't realize that there can be something which is wrong in the system, because these things are never spoken about, right? So no one knows what happens.
And
So
these symptoms are so, they are sometimes so bizarre, right? I mean, a patient is
yeah,
having
it's very
intolerance to lactose, and she just feels that this is
correct.
the way I'm supposed to be. But no, I mean,
Absolutely.
she's not thought of it that maybe I'm not supposed
Correct.
to be like that.
Correct.
They
That's
haven't
what
thought.
they feel, it's normal for them.
Hmm.
It's absolutely normal for them. I mean, because I remember for the longest of time, I thought that I was having IBS and I was allergic to God knows how many food
Right.
groups. Yeah. So before knowing that I had endometriosis, and I could actually join the dots, why it was all happening.
So,
Where obviously when I had a intestinal block, that's when everything,
wow. Yeah.
fell into place.
Yeah.
But people don't know about it. So I think first and foremost, education is something which is extremely important right from the
Yes.
time
Which I
a
think you're
child,
doing very well.
ma- I think we all are together trying to create awareness about it towards, we are all working towards a common
That's
cause of,
true. That's true.
towards about endometriosis. We just have to, you know, start talking about it so that people don't suffer. People just shouldn't suffer with this disease. It's like dreadful. So coming to technology, the second part of our session. So technology now is like coming big time when it comes to medical healthcare
True.
system. So what are some technology-based tools or apps that you can assist in tracking and managing your endometriosis symptoms? Are there
So,
anything which are
when
available?
we've started off at some point of time, endometriosis was at that point of time really not. So, let me tell you how I started training myself in endo. When I went to Australia after I finished my graduation and all of this here, this was way back in 2003, 4, 5. At that point of time, this is the first time I saw excision endometriosis surgery. There were two of my consultants who were in the Sydney endometriosis group, and it's the first time that I saw that you could actually remove these endometriosis. And I used to wonder how come these people are seeing so many of these patients with endometriosis. There's just so many patients who were, coming there, and I said, how come? Like, how come all this while throughout my MD training and my other fellowship that I did 2 years after that, I never saw so much. I mean, I saw, but I probably didn't realize that it was endometriosis. I
Correct,
think that's what it was.
correct,
So
correct.
that's where at that point of time, not many people talked about endometriosis, and there was not
Yeah,
so much of knowledge. I think internet also was just kind of beginning and starting off. Thankfully, now we have everything. We have smartphones. Everyone has We didn't have smartphones at that time. We had like the regular phones. Now that we
right.
have smartphones, we have a lot of things available to help patients. So, it's also a little difficult for a patient because there's so much of knowledge that they have to swim through before they reach the correct part. But there are enough number of apps and things which will help you, for tracking or understanding what your symptoms are all about. So there are a number of apps like Endometrics, Eve, Clue, Vona, Flutter, all of these. There's a lot of apps. If you go on Google Play, because we were going to talk about this, I actually went and checked, and I think I found about 100 plus apps that are meant
Oh,
for
amazing.
if you just type endometriosis in the search group, you will find like 100 plus apps on endometriosis that are there on it. Okay, I think what these apps are essentially going to do, of course, they are not going to be a replacement of how we diagnose endometriosis from a professional point of view, but for a patient to put their symptoms across to you. Sometimes you forget, you have that pain and you're so bad, but then after that, because after the period is gone, you're better, you forget, no? You forget that you had such a
Right.
bad time and you
Right.
don't really.
Right.
So when you start documenting this, you realize that, I had these 4 days of the month where I was really not able to do anything. And then that, in
Correct.
fact, counts a lot because that's 4 days in a month is like 48 days, almost a month and a half in a year. So,
Absolutely.
so when you put this in perspective for the patient, for themselves also, it makes them realize that they really need to take help for this. So there are a number of apps. I mean, there's something which also helps you to scale your pain. So there's something called as pain scale. There is something called as mind docs, how endometriosis affects you mentally, and you are going to, patients go through depression, they go through a lot of issues at home, people don't understand what they're going through. So mind doc is something which helps them with their mental health, helps them to understand what's happening with them. So there are lot and lots of apps which are actually, I would say, go for the ones that are genuinely going to give you a feedback about your pain, give you like a graph which tells you your pain cycle, and also sometimes tells you which other symptoms that you're feeling. You have a place to put it in. So if you have that on your phone and you go to your doctor and you show them this, that look, this is how it is. I mean, we have period apps. Patients are now using it regularly where they track their periods to tell them ovulation time and they tell them how much period they had and all of it. So this is going one step ahead. So,
Correct.
specific for endometriosis, looking for your symptoms, documenting it so that when you go ahead and speak to your doctor, at least the doctor gets a very good perspective on what actually is going wrong with them. And it will probably help them to diagnose or help them to understand which way they can help them, whether this is just
Correct.
going to be,
Correct.
whether you need surgery, whether you need any more investigations, whatever it is. Yeah,
So, so now that we have technology, I think we must use it
we
because
should.
there are lots of apps which can, help you record your symptoms. These are some, and this is something which is very important for patients who have chronic diseases because every day is a different day. Every day you wake up as a
Hmm.
different, with a different symptom, with a different mindset. So I think the mind doc that you said was also like absolutely wonderful. To all the audience who are putting in questions, could you just put the questions towards the end of the session? Because otherwise it will just get lost in the chat. So just hold on till the end of the session and then start putting in the questions. We will take all the questions. So, Doc, now, what are some of the telemedicine options available for an individual with endometriosis, and how can they be, how can they be utilized to receive remote consultations and support?
So we COVID has actually taught us telemedicine,
Right.
and because of that, we've actually, our hospital actually developed an app to allow patients to interact with us online. I think
Mm.
telemedicine helps a lot because, see, like I said, now the world is connected, so it's connected so well. We have so much of information all along us, and it's possible now for endometriosis patient to take a consult overseas.
Right.
You transfer your MRI images, you transfer your ultrasounds, and you can have a very honest opinion or a perspective on what you are going through, and then probably you can come back and discuss with the doctor. And I think as doctors, if a patient was to discuss of what has happened with them, we should be open to listening to what other people also have. We are all very well connected. So telemedicine, I think, is going to really help because it's going to help patients to get a perspective where they are not sure, and there are experts of endometriosis across the world who have done thousands of cases, a lot of research on this, and if they are able to get their expertise in to make a decision, I think it's excellent. So, going through online consultations and contacting these specialists across the world. So there are people who do pelvic neurophysiology, which is basically
Yeah.
mapping pain. So these are patients who have chronic pelvic pain. Now, we probably in India, very few of us have actually gone ahead and done this training. But it's for those who don't have access to this and who have chronic pelvic pain, probably a consult with one of those experts would actually help them to know what their options are, because it's
Correct.
probably not available at the moment in India. So
Correct.
yeah.
That's right.
uh,
That's right.
mhm.
So, you have told me about some apps which are available for endometriosis. So are there something which are specifically made to, assist in tracking your menstrual cycle and predicting ovulation, especially in endometriosis? Did you come across something like that?
No, but there is apps for your normal regular periods and
Mm.
ovulation. There are so many of them
So
available. My
it's
period
the
and
same for the
is
endometriosis patients also, right?
is the same. It's the same, yeah.
Perfect. I mean, I think technology has made life a little simpler.
It has, yes.
Yeah. So Doc, uh, are there any emerging technologies like artificial intelligence or anything like that being used in endometriosis diagnosis or treatment? And what is the benefit that you think of?
Artificial intelligence, chat GPT. Yeah, I think the buzzword now. Everybody wants to look about it, and I think yes, artificial intelligence is going to infiltrate everything.
Yeah.
Okay, and like I think the best way. I mean, there are enough number of studies which have been done to use artificial intelligence for different things. Okay, it
Hmm.
can come from actually quantifying. So basically, what you're looking here is to understand in the population what was it that one thing that helped you to diagnose endometriosis for a cohort of 10,000 patients,
Good.
for example. So you
Hmm.
may send gene patterns, you may send symptoms, you may send your blood reports, you may send ultrasound, MRIs, and then this AI would actually collate those 10,000 people's sample of endometriosis and then come up with the like a mental a map or to say or a machine learning which you can call it, where they would be able to say ki, okay, if this particular person has this gene pattern where they have like out of the four sisters two of them having endometriosis, where their some of their markers are high, or if their symptoms are more particularly like dysmenorrhea, dyschezia, dysuria, which is painful periods, painful urination, painful stools, and these out of these five, these things are matching, she probably has endometriosis. So symptom point of view, using artificial intelligence can actually has been used, has been studied, though the studies that have been done so far have not been a very large number, but I think we are getting there.
Yeah.
So of course individually evaluating the patient and as a doctor then making a decision, informed decision after going through all of this will help, but probably it will help you to point yourself towards it to say, okay, maybe this patient has a higher degree of suspicion of endometriosis and maybe then we should investigate her further. The most popular one where AI is being used currently in endometriosis is to look at diagnosis of endometriosis on radiology. Now,
Hmm.
like you said, you had endometriosis, you had symptoms, and you got ultrasounds done, but your uterus, ovaries, fallopian tube came normal. Nobody thought about it. Nobody said you have this.
Right.
Uh, that's because probably the method and technique of doing the ultrasound was not as it should be in endometriosis patients. It always has to be a transvaginal or a transrectal scan. It has to be with a certain algorithm of looking at the anterior bladder, the pouch reticulus, uterosacral, rectum, looking for these lesions, nodules. Then probably an MRI also, how you diagnose it, what is the cuts that you should be making, what's the distance between the two cuts that you should have, what kind of T1 images, T2 images, how they should be looking. And the old blood will look in a certain way, newer blood, newer hemorrhage will look in a certain way. Now these are all things which are being learned by us slowly. Everybody, even radiologists, we have to coach them. They have to, those who are interested in endometriosis have to actually go and coach themselves again to look at how to diagnose with these things. So what AI
Right.
is doing is actually getting again MRIs, ultrasounds of patients who have had endometriosis before, and bringing all of this together in a single platform. And then next time when you put in your MRI, it reads it, and based on what the data it has, it will tell you that okay, this point, these are the places where you probably have your endometriosis, and this is what you should be looking at. I think how I see it is for someone who has a very busy radiology practice and maybe is not able to give the kind of time and attention, maybe for them putting that MRI images or the ultrasound images on this app or this artificial intelligence, running it through that will help them to realize that this screening on this screen, this patient will require a better screening, will require a little better, a little
Yeah.
more detailed scan, and probably point them towards that. Also, I think for those of us who don't have very good machines, they're in remoter areas, they don't have a very good ultrasound machine. I think for them also, again, if they get the ultrasound done and put it through this artificial intelligence, it's actually going to help. This is helped in conclusively helped in patients. Artificial intelligence has helped patients who, like if you have someone who's undergoing what is called as non-stress test, NST. A pregnant patient is going through NST, which is where you check your heartbeats of the baby. And you know how we used to read it when we were in med school doing our MD, was to actually look at the chart and then go back to seeing how many beats and what is the acceleration, deceleration, all of that. And then we used to make a conclusion. It's reactive, not reactive, equivocal. But there's an AI for this now, and it's being used widely. Okay. And it has a 96% accuracy. So see,
that's amazing.
you are, so you are actually improving your accuracy of reading something which you probably will do a good job on. But what if you miss something? What if you don't look at something which you should have looked at? I think this kind of catches those gray areas where you may have missed something if you had not looked at it, if you didn't happen to look at it more carefully, or So I think that's where artificial intelligence is actually going to help. So all of those negative ultrasounds which are done, which didn't show anything, I think using the artificial intelligence will actually help us to pick up, look, this is probably a suspicion lesion, and what the patient is telling you in terms of symptoms, collaborate with it. They can also help to pick out what is negative. So, they are also including other things which cause pelvic pain. So one of the other things that can cause pelvic pain is pelvic varicosities. A lot of patients will have extreme pain, but ultrasounds are clear. Sometimes even laparoscopy is not, but though in laparoscopy you can see pelvic varicosities, but ultrasounds are clear. There's nothing. The patient has pain, consistent pain. There's a young girl who came to me. She was around 18 years of age. She was doing her master's in Hong Kong, and her parents brought her in panic because she had extreme amount of pain. And she used to like, she was living by herself, and she used to find those 3 days very difficult to actually survive, and she didn't know what to do. And ultrasound perfectly clear. I said, look, we don't know, but let's do a laparoscopy diagnostic and see, because your ultrasound. And she was she was an unmarried girl, not willing for transvaginal scans. We did abdominal scans. I said, this is not going to tell us anything. Let's do a laparoscopy. On the laparoscopy, what we find, and she had pelvic varicosities. She had, and pelvic congestion syndrome is a known entity which causes as bad a pain as you would get endometriosis.
Right.
So she probably needed the laparoscopy to tell her, and then our therapy went in that direction, and she's comfortable now. She did not need to take OC pills, and none of those things happened to her, because we knew what it was, just because we did a laparoscopy. So this artificial intelligence is also promising that it can help us to look for other causes of pain which may not be endometriosis. Again, that's very important, because now a patient with so much of pain in the abdomen, with pain with periods, will come to you. Young girls will come to you, but there's really nothing. And what do you answer to that patient to say, look, there's nothing, I don't know why you're having this kind of pain. So I think it rules those things out also. It tells you whether there is anything associated other than endometriosis which could be causing the pain.
And the worst thing is, Doc, I don't know if you would agree with me, a lot of doctors don't agree that they were not able to diagnose the reason of their pain. They would just say that it is something which you're exaggerating. And they push the patient to the corner. I have gone through, so I know how it feels to be pushed to a corner when you are going through so much. Sometimes there comes a time when you start doubting yourself, whether you yourself are saying the truth or the doctor is telling the truth. So somewhere there's a lot of turmoil within yourself then. But anyways, and surprisingly now, I mean, when we're talking about AI, I was happily surprised when last couple of months I had around 3 or 4 people who called up and who wanted to talk about artificial intelligence and diagnosis of endometriosis, radiology, and things like these. And it was like, I felt so happy that people are now working towards endometriosis.
So there's a trial going on in the UK. It's called the Defend trial. They've just started it, and they are recruiting now. patients who have endometriosis to kind of get a database. I mean, it's going to take time because
Obviously.
not everyone is the same. As we know, human body can be so different, as you know as well.
True.
Not everyone has the same line of teeth and things like that. But the point is that it's going to take a long time to get a huge enough database to cover, the
Correct.
250 thousand women who have endometriosis. So, but I think it's a good start. I think it's a good start, even if we can start with the basics of diagnosing. It's going to make a very big difference. It is going to make a very big difference to them. Yeah,
Makes sense.
yeah.
So now let's come to the topic of your interest, robotic surgery.
Yeah.
So what exactly is robotic surgery and how is it different from the traditional surgery? And also, I would want you to tell our audience what are the benefits of going for a robotic surgery as compared to the other surgical techniques.
The benefits of going to robotic surgery is the surgeon goes to the other room to have a coffee and the robot operates. So yeah, I get a break. So no, it's exactly not that at all actually, because it's just automation, or let's say artificial intelligence being applied to minimal access or laparoscopic surgery. So here you are having a system where you are getting a three-dimensional view. So you know how when you do laparoscopy, you have a screen which is two-dimensional.
Right.
And you can have a 3D laparoscopy also, but essentially it's a screen. It's like watching a screen, a television, a little bit at a distance from you. And you put in instruments which are state-strict instruments like this. They have no movement, and they go in and they do surgery like this. In this, it has only up and down and in and out kind of a motion. It has no other way of working around it. There are some limitations in terms of how this surgery can be used to do some pelvic surgeries. And that's where the robot came in. So the reason why this was called Da Vinci is the one that I use. There are other robots available now across the world. But Da Vinci was essentially because Da Vinci was the one who made the first robot for
Mm.
the Roman emperor. So so that's how that name was used as Da Vinci. It's called robot because I'm controlling the system from a distance. So I'm robotically, or through a thing, I'm controlling the system from a distance. So here, what happens is I'm sitting on a console, which has I look into the console and I'm looking in straight into the patient's abdomen. I have no screen interface.
Right.
So it is like I am looking in and I have a three-dimensional view, just like I would see when I'm seeing it with my naked eye. So I look in and I have a high definition magnified view, almost a 10-time magnified view that I can see. The other advantage of robotic surgery is that it has wristed movement. So my hand, which was straight like this, has now got a movement, which is almost 360 degrees it's able to move. So it's able to go into the pelvic cavity is narrow. It is covered by bones on all sides, and there's only so much space. And the depth of going into the pelvic, sometimes, like if you were to do a diaphragmatic endometriosis, or if you were to do a sacral nerve root endometriosis, the robotic approach makes sense because the instruments are very delicate, very specific, and these are confined in narrow spaces to do surgery, and you need something which is able to turn itself around and go in and do the particular surgery. So that's where robotic surgery is extremely helpful. I think the vision that you see with this particular robotic surgery is so superior, that being able to identify endometriosis well and do a good excision surgery is really helpful when you're doing it with the help of the robotic surgery. The cuts on the tummy are the same. There are 3 or 4 incisions made on the tummy wherein you do the surgery through that, and you look at the screen, and I mean, you look inside the console and do it. But the biggest advantage here is, I think, the vision and the capability of doing more complex procedures more precisely with less pain and less bleeding as well. So that's where robotic surgery comes in. We started the program long ago. It started in 2005 in the US, but here in Kokilaben we started in 2012. But I think the ratio so far has been less of robotic and laparoscopy because there are some financial constraints that are there with it. But I think now even the insurance companies are getting on to the fact that yes, robot assistance does have a benefit. There's a very big trial that's coming up called the Robo-Endo trial. This is going to actually compare laparoscopy versus robotic surgery for endometriosis surgery. So, up till now, we have small studies, 25, 30 patients, our own series of 50, 60 patients that who have done robotic surgery for endometriosis versus laparoscopy. And we found that, of course, personally, I feel that yes, if I'm doing a robot assisted surgery, the patient is much more comfortable, has less pain, less bleeding chances, and a very good and a complete surgery can be achieved in a lesser time as well. But these things are going to be probably come out as a fact sheet once this trial comes out and we know, where we stand in terms of the benefit to the patient as well. So robotic surgery is excellent. There are other things that can help. So the robot surgery also has a green filter, So what happens is when you're doing endometriosis on the intestines, sometimes you need to know the depth or you need to know exactly where is a normal intestine, where is the endometriosis there. So that's where you can use this dye called ICG, indigo cyanine green. You inject it in the blood system. Whatever are the fibrotic areas will not light up, they'll be gray, whereas whatever has blood will be green. You have a window period, a very short window period to diagnose this and actually remove that entire nodule out, but it actually helps to guide you to be able to remove that entire fibrotic area and leave the good part of the bowel behind so that you do a good complete excision. So the ICG dye usage in robotics is very good. It also helps to delineate the ureter. That's the pipe that comes from the kidney going to the urine bladder. It's often engaged into endometriosis, is often adherent, stuck, hidden because it has lost its natural path during endometriosis surgery. So you can flush the ureters with the dye. And then whenever you want to figure out if there is where is the ureter, all you need to do is put the green filter and to start shining green. So you know that this particular thing has endometrio has ureter is over here, and I need to avoid this, and I need to go in this particular place. So that is the other thing. I mean, this is traditionally being used for sentinel lymph node mapping, which means ICG was used for patients who have cancers to look at only those lymph nodes to be removed which are actually showing some path from the organ to that particular node, so that you're not removing too many nodes and you're protecting the patient from extensive surgery unnecessarily. Interesting, we had a patient who actually came to us, she had come to me when she was 23 years of age. And I had told her at that point in time she needs surgery, she has endometriosis, but she was quite sure that she didn't want to do it and she was not married yet. Mother was worried, okay, if I do this surgery, how will she get married? And this is a very sad thing that happens to endometriosis patients, that if they've had the surgery done, either they find it difficult to get married, or even if they are married, the husband doesn't want to take the onus of actually looking after a patient who has endo. They just want to, I mean, it's really sad, but I've had patients who come and say, what do we do, or speak to the in-laws, and it's quite a sad thing. But this patient didn't actually get anything. That she took multiple injections, took medications and all of it, and after she comes to me after almost 9 years, that now my pain is unbearable. I'm married now, I want to have a child, but my pain is so bad that I can't have intercourse, and I've taken so many medicines and I can't deal with this anymore. So we went ahead and did robotic surgery for her. And while we were dissecting the pelvic floor, I saw these lymph nodes on each side. They were they looked quite large and abnormal with the typical bluish hue of endometriosis. And I think these are one of the rarer cases where you can find endometriosis has actually gone to the lymph node. So we had to do a lymph node resection for that patient, and all of those lymph nodes came out positive for endometriosis. So, that means like if you just reach the lymph node, it can reach your, your blood vessel, your aorta, your heart, pericardium.
Absolutely.
I mean, there are very rare cases of actually endometriosis reaching the lining of the heart as well. I mean, so that's going to be difficult. But then this is what I read in the literature later was that so far they had very few cases of patients with lymph node endometriosis, but they were initially diagnosed as they had pain or they had vague symptoms, and they were diagnosed in MRI as having probably malignancy. So it went from neoplasm diagnosis to endometriosis. Yeah. So robot in such instances actually helps because the vision was so good, and that we were able to pick it up immediately in that particular surgery.
Amazing. That's like so wonderful to hear about what developments, I mean, the way medical science has advanced, and I think robots have gotten a different perspective altogether. Let me just check if we have any questions.
Yeah, sure.
Just 2 minutes. There were some questions. Hold on. find them only, it seems. There's so many chats. I mean, there is so much of chat.
Yeah. I think
Transparent, this
Hemant said
really.
hello to me. So hi Hemant, how are you?
Hi, Dr. Hemant. I know.
Yeah.
No, I can't find the questions. They are lost in the chat. So if there is some question, you can put it in. If somebody wants to ask a question, you can put it in. But in the meanwhile, Doc, is there something that you would like to end the conversation with?
Um, I think the only thing that I always say is whenever as a patient or as a young girl around you, as a lady around you, if you see a young girl or as a young girl, if you're seeing this and you are experiencing pain, please recognize it as being a problem. Don't think that women are not supposed, they were not meant to tolerate pain. And why should you? There is nothing like, why should God even make anything which is going to make us so uncomfortable? I mean, surely that was not planned or destined by nature or by God. No way, right? So if you are having pain, which is not normal, it makes you feel that you have to get out of your comfort zone. You can't do your work and don't ignore these symptoms. If you feel, go to the doctor. If you feel that the doctor is not answered your question, please go to another doctor. Make sure that you do this so that you know what your answer is. Don't take things which are told to you in terms of it's okay, you'll grow out of it, you get married, you'll grow out of it, get pregnant, it'll go away. So, don't believe in all of these things because the symptoms are very, very real. The problem with endometriosis patient is that they're all very beautiful women, by the way. All endometriosis patients are very, very beautiful. But the poor things have been gaslighted and undermined for so long. I think they need that ear to be listened to listen to, and they need to be understood, and they should be their own champions for their cause. If you have the
True.
symptom, you have the problem, why would you accept somebody saying, look, no, there's nothing wrong with you, but there's something wrong, right? You have to take injectable painkillers. You are in so much of pain, you can't work. That's not normal. So don't listen. If you feel that that's the advice you're getting, go ahead and seek another advice. It's fine. You can do a teleconsult. You can do a telemedicine now, and you can consult anybody across the world and understand if that symptom is real. Because then the help can be taken care of, and you can ask for help or you can get the correct kind of help. So don't undermine yourself and undermine your symptoms. Listen to them and make sure you go and seek the correct help. It's very important. That's what I would like to tell them all. I think
Absolutely. I completely agree
there's
with
one
you.
question that's come up. Is it advisable to do pelvic area excision surgery, including bowels and diaphragmatic endo excision at the same time? No. Generally, if you are having bowel resection with pelvic areas, we would not want to do the same thing. Diaphragm, they're very, very difficult and complicated surgeries on both ends, right? So you would not want to do the two together. If at the time of the bowel surgery we see endometriosis in the diaphragm, we will probably take it up as a second time surgery, not at the same time. No.
Okay.
There's
Makes
one question
sense.
that I found. Yeah.
That's what I'm saying. There's so much of chat. Oh, okay. Yeah, that was the last question that came again. Anyways, Aarti, yeah, absolutely. What you said is right. Had she just listened to you initially, but family and societal pressures really affect life in endo too. Absolutely true. And it is so painful to even listen to stories like these. But anyways, Doc, this has been such a wonderful conversation and such an informative one too. And I'm sure your patients are really, really fortunate. They have a doctor like you to take care of them.
Thank you.
And I wish you a lot of success.
And thank you
Yeah. And
very much, Shilpa, for doing the work that you are. Please keep up this thing, get more and more people to, share their experiences and their, whatever is the latest. I think that's very important, because now with this, I think a lot of people will probably go back and look at their apps to see what can they do
correct,
to,
correct.
map their pain. And some of them may get a sudden awakening to realize, oh my God, I have a problem.
True, true.
So,
Absolutely.
yeah.
And in case of the audience, in case you want to ask some questions, you can put it in the comment section. We would get back to you with the answers. And also, if there is something that you want us to speak about, or in case there is somebody else you want to see on our podcast, then probably please let us know. We would be very happy to host them. And this session was specifically dedicated to my brother-in-law, who was like a big, big support for me. I mean, he was like one of the biggest cheerleaders that I had. So wherever he is, I'm sure he would be very proud. So see you
I'm
all.
sure. Yeah.
Have a good evening and
Thank you.
have a pain-free life ahead.
Yes,
See ya.
definitely.
Bye-bye.
Thank
Bye.
you. Bye.
Thanks, Doc. Bye.
Bye.